This is the case of 68 years old man. He underwent to cholecystectomy for cholecystitis 3 months ago. A CT scan showed a cyst in the body of the pancreas with no context of acute pancreatitis. An MRI revealed branch duct IPMN. And the patient is scheduled today for US evaluation with Dr. Iglesias and Dr. Archidiacono.
We are just with the scope taking a look at the body of the pancreas. We've already went through the case and we will focus because it's very interesting to what we found. But you can see here, whenever we want to evaluate a cystic lesion, it's very important to take a look at the parenchyma of the pancreas because it's very important for the differential diagnosis. Because if you find data that may be related to chronic pancreatitis, that can give you some other options. Yeah. But in this case, the pancreas is almost normal, mainly for the age of the patient. And another very important thing is that even from the stomach, here we have the superior mesenteric artery down here. So we have the splenic vessels. We can even see very nice the head of the pancreas from the stomach. That is down there, mainly also with the common bile duct. And also with this is the bile Beerson that Paolo is showing you.
That is clearly going.
Is this with the slim scope?
No, this is with the therapeutic scope.
No slim scope, therapeutic scope. And so you see the head and the pancreatic duct going down in the head. So it's very clear the image that you can obtain. This is very interesting point that you are underlining because sometimes you have patients with previous gastric surgery and they are referred for pancreatic head lesion, and you can show that if in these cases you can provide good images of the head.
Because now we have the position of the scope now is even in the very upper part of the stomach body, so you can really see the head of the pancreas from the stomach very nicely, so you can evaluate lesions in the head of the pancreas even if you are not able to access to the duodenum.
Absolutely.
Well, now we're going to...
One of the things that, Julio, one of the things that helps you with that is that your focal point is very nicely placed in the middle of the image.
Exactly.
And that's very important if you want to get that depth of penetration. That's very important.
Absolutely.
If you move the focal point too near the probe, it would then reduce your penetration.
Absolutely.
Correct. Yeah. Really.
Well, now we're going to focus on the lesion that we've already checked. Now we are again in the body of the pancreas with the splenic vessels, and we make a clockwise rotation, just slightly pulling back the scope, and we start to see something in the screen. And this is the lesion that has been evaluated by the MRI. But honestly, we've been discussing about this lesion before, and I cannot say that it can be or cannot an IPMN because it's a quite strange appearance of the lesion for an IPMN.
And regarding also the relationship with the pancreatic duct.
Exactly.
Sorry, Nick?
So would you call this oligocystic, or there's not many cysts, are there? But there's
some
more than you would expect.
But whenever we evaluate any kind of cystic lesion, it's very important to see the features.
Yeah.
And we see here there is an enlargement of the wall, very clear. You see that Paolo is showing us with a clear. We're going to measure it, and this is one of the worrisome features that have been established both in Sendai and in Fukuoka criteria. So this is really a sign. You see, it's 4.9 millimeters, the size of the wall of the cystic lesion. We've also, I think, in these cases, although elasto sometimes can be difficult whenever you have some cystic component, because it may misunderstand the image. But I think it's also important to take a look, and you see in the upper part of the lesion.
You see how the outer wall is blue in this, particularly in the upper part of the lesion. You see this blue area that corresponds to the wall, and this blue area that corresponds to the wall of the lesion. So this means that the lesion has a thick walls and hard walls that are really suspicion and worrisome feature for a malignancy. I think that in this case I would suggest to perform Sonoview also. What do you think?
Yes, I'm more and more using Sonoview routinely in all cystic lesions, because even if you have a tiny, small, with a normal appearance wall, you inject Sonoview, and sometimes you can further detect small changes based on Sonoview images that can really make a change in the management of the lesion. You can detect enlargement of the wall, not detected by the B-mode imaging, but and also it's essential for for detecting small nodules inside of the cystic lesion. So we are more and more using routinely to clearly establish if there is or not worrisome features in the lesion. So we will go to use the Sonoview in this case.
So
Is the pancreatic duct normal proximal to the lesion, towards the tail?
We are towards the tail, and we have not clearly seen a relationship between.
oh yeah.
Yeah.
So
Okay.
we are going to.
There is no clearly
No.
There is no relationship with the.
In this case, it's probably the most sensitive technique could be MRI, MRCP with secretin injection, just to detect communication of the lesion with pancreatic duct, particularly when the pancreatic duct is very small, like in this case. If you want to be sure that there is any kind of connection, it's better to do MRCP and secretin test for this.
Yeah. In fact, what we used to do in our unit is whenever we diagnose at the first time a cystic lesion, that our first approach is always AUS.
That's
we
perfect.
go after for an MRCP. And based on AUS, we decided to discuss with the radiologist whether we need a secretin MRCP or just a standard MRCP.
In our
It's
unit, we usually, if the communication is very clear, we don't perform with the secretin. But if there is no clear communication, we prefer to use secretin.
You move for the contrast.
Yeah.
And now,
Yeah.
okay. Please.
Okay.
Subito. Yes.
Subito.
So now we're injecting the Sonoview with the guidelines of Mark. Remember, you have to be straight in the vein to have no problems
Was done.
broken the
Was done.
bevels.
Okay, now.
Another important thing is that the focus in the images should be below the lesion.
Yeah.
That's also very important.
And you see the wall. You see the wall. You see that the wall is taking the Sonoview, and there are also vessels in the sector. So
Maybe it's serous, huh? No?
yeah, but
No?
the problem is that the wall is too thick,
yeah,
too
for
thick for a serous. But to me, it could be neuroendocrine.
Neuroendocrine.
Could be neuroendocrine. But I think that I don't know if you agree, guys. I think that in this case,
Biopsy.
FNA is
Yeah,
mandatory.
yeah. What kind of needle do you want?
Since it's a cystic lesion with a cystic component, I prefer to go for a standard cytological needle instead of a Procore. And in these cases, since I would like to get into the wall, probably a 25 gauge needle,
25 gauge normal.
maybe it's a very good option
I agree.
in these cases.
I agree. Because in this case, you don't want to aspirate to suck the fluid, but you want to go for
Exactly.
the cytology of the suspicious wall. Okay?
Yeah.
Do you agree, Nick?
So we will.
Yeah, I think this is a very nice demonstration. There's clearly enhancement in the wall at an early arterial phase, wasn't there?
Yeah. There was, and
Makes it suspicious for a neuroendocrine.
yeah, and the flushing was very quick as well. So it seems to be really in a case like that. So, but the other thing is that is not so typical of a neuroendocrine to be oligocystic or multicystic. So the case is very interesting also in this regard. So I'm very curious to hear about the cytological diagnosis tomorrow morning when we will review the cases during the second part of the session.
Well, okay, so for the puncture, as a standard, and this is just the technique for any kind of puncture, we first check for vessels, and we see clearly this is going to be quite safe. And we've discussed, probably in this case, the best thing also for a cytological needle from the beginning is that we can sample from the first part of the wall, from this part of the wall, and we can take the needle to this area, so we can really sample from this part, the complete area, and this is one of the things of using a cytological needle.
Perfect.
So we will fix, and we will use the elevator. We just use the standard technique.
You see how it's perfectly clear.
And now we go. It's quite soft.
Yeah. Going with the 25, so the
Yeah.
stylet of the 25 is smooth on the tip. So as you see he has
Okay.
retro, and now you are in.
We're
So-
inside.
Yes.
So we
perfect.
will try to go
Okay.
to
nice.
the enlarged wall.
Do you standardly use the suction, the syringe to suck this?
I usually use it always.
Always suction.
And
So
in these cases even more.
even more, because you want to take everything.
Yes, because I'm mainly focusing on
Yeah.
on accessing this enlarged part of the wall.
Yeah.
I like to do it very smoothly.
Yeah, and some data reports that somebody cross the wall when they want to perform a good cytology of the wall. What
Yeah.
do you what's your feeling
I
about
used to stay inside of the lesion because the risk of bleeding may be
Higher.
higher if you
Yeah.
just try to trespass the wall. But at the end, you can do it as the procedure is going on. You see if there is bleeding or not. In this case,
Yeah.
we see there is no bleeding.
No bleeding. Yeah.
So it's quite safe. And what is very important is to sample
Yeah.
the wall. That's what
Yeah.
I am trying to do. And in
Yeah.
this case, there is the idea of the slow pull technique or
Yeah.
not using anything. But since we're trying to make a sample of a very small part,
Yeah.
it's quite nicer to have some suction
Yeah,
because
becau-
probably you will get some more needles. More cells.
Cells, yeah. Yeah, because actually this slow pull is better for the
Solid lesion.
lesion,
So we
where
try
you
to
can go in and out very.
And now
very
we're just
easy.
moving and trying to sample
Yeah.
all of the part of the wall
Perfect.
because as
And then you go back and take also
Yeah.
the upper part like
and
that.
now we
Oh
are here
yes, like that.
and
Really.
slowly and now we go in this
Okay.
part.
Yeah. So you see that this sampling. That was the harder part, the hardest part of the lesion that we saw by elastography. So it's taking care also of this higher part. So this is a perfect explanation and demonstration of the technique when you want to perform the biopsy in a cystic lesion with a thick wall.
And another point in this case, just from the technical point of view,
Yeah.
is whenever you make a biopsy of a cystic lesion, you just need to try to do only one pass,
One pass.
and you only need to use and the role antibiotics is under debate
Yeah,
today.
absolutely. Yeah, we have some liquid as well. Okay. Wait.
Will you give her antibiotics?
Okay.
Julio,
Tell me,
will you give her
Antibiotics.
antibiotics?
Yeah.
we're using antibiotics, but
Which
there is a
can-
couple of papers coming into the field that said that there is not an increased number
is.
of infectious related to
Yeah.
the puncture of cystic lesions, independently on if you give or not antibiotics.
Yeah,
However, I give
Yeah,
antibiotics.
I think that this because this everything comes from just one study many years ago.
Really?
There is a microcore. Fantastic.
Okay.
And so everybody after that first report came with antibiotics, but there is absolutely no evidence that antibiotics are
Mandatory.
Mandatory.